in cancer patients, diagnostic testing is the whole axis of which diagnosis is made. So a lot of times it tells you where the primary tumor is. It tells you how far the cancer is spread, to what extent it is spread, whether it's made it into the lymph nodes. And it tells you the places that it hasn't gone. It tells you the places that are free of disease. And all of these have to be taken into consideration when you determine what method and means you're going to do to treat the cancer. Before any type of decision can be made as far as treatment, you have to do staging. Lung cancer has really become exciting in the last few years simply with the invention of PET imaging that has improved resolution. Probably the number one question that cancer patients need to be asking when they're sent for testing is, how old is your equipment? How long have you had it? Previously, the resolution of a PET study was always thought to be a sonometer, 10 millimeters. But with new PET scanners, we can see lesions as small as 3 to 4 millimeters. And when you're talking about lung cancer, in the lung, you can't tell the patient to stop breathing for the exam. They just, unless they're an Olympic runner, they can't hold their breath that long. So we have what's called motion management, which means that lesion is moving in the lung, but our computer is making up for the motion. So we can actually see the lesion as it moves up and down, which gives us better resolution. PET imaging is used to determine whether or not a lesion in the lung is hypermetabolic. Hypermetabolic just means that it uses more glucose than background. Now, things like the heart, liver, colon, brain, they're always hypermetabolic. The brain and the heart use sugar or glucose in their normal metabolic pathway, so they always take up more of the tracer, if you will. But pulmonary nodules that are malignant also take up more of the radiopharmaceutical. And when you have good resolution, you can determine early on whether or not these are malignant, making them more applicable for a surgical resection. Oftentimes, when the resolution is not very good, you'll go to your physician, they'll say, well, we don't really know what it is. You just need to follow it up in 3 to 6 months. And then you go back, well, it's bigger, and now it's touching the pleura, and you can't be resected. So the better the equipment is, the better the resolution is, the earlier the diagnosis can be made, the faster you can determine whether or not it's resectable.